Bismillahirrahmanirrahim. Okay, ये इसमें MCQ के लिए समझ to understand this MCQ we have to see the circulation of the cerebellum. Look here, anterior cerebellar artery, anterior inferior cerebellar artery. It supplies the lateral aspect of the cerebellum, lower lateral aspect of the cerebellum, correct? Anterior lateral aspect of the cerebellum, anterior and lateral aspect. So she scans the low density non-enhancing area along the right anterior lateral aspect of the cerebellum. Density along the right anterior lateral aspect of the cerebellum. Diagnosed cerebellar infarction was made. What artery is involved? Anterior and inferior cerebellar artery, correct? Infarct is in anterior and lateral aspect of the cerebellum. So anterior and inferior cerebellar artery. Anterior and inferior. Next question number 38. Investigation of hyperparathyroidism and a focus of uptake is seen on the technetium and MEB scan with corresponding area of increased uptake on the iodine 123 study in the region of the upper pole of the right lobe of the gland. What is more clearly called for this finding? Multinodular goiter with prominent nodule. Okay, this is a multinodular goiter. This is autonomous. Okay, this is hot nodule. This is cold nodule. Hot nodule, cold nodule, and multinodular goiter. Okay, now wait here. Investigating hyperparathyroidism and a focus of uptake is seen on the Q99 and MEB scan with corresponding area of increased uptake on the 123. So you're saying that there are more than one areas of increased uptake on different scans. So diagnose multinodular goiter with prominent nodule. None of the other options make any sense. The gain for parathyroid answer is multiple thyroid increased uptake on iodine 123. There are more than one focus of increased uptake. So multiple nodal goiter with prominent nodule. There are no options. Other options make any sense. Next question number 39.
Excuse me.
G.
One question is that how we can differentiate between technetium MEB scan and iodine 123.
But, I'm not sure. I'll just see that afterwards. But technetium MEB scan and iodine 123. I'll check afterwards and I'll tell you. In the group I'll discuss. I can't remember now.
Okay, sir.
The question number 39. Patient was catapulted from a motorbike. He had a cervical spine X-ray demonstrate a small triangular fragment of bone anterior and inferior to the anterior margin of C4 with widening of the spinous process at C4, C5 with mechanism of injury, hyperflexion. So this is okay, the bone fragment. For example, this is C4 to C5. In front of it, there's a small triangular fragment of bone anterior and inferior to the anterior margin of C4 with widening of the spinous process of C4 and C5. So this is easy. This is here. The look here. If you have a this C4, this C5. So here they're saying there's a triangular bone fragment over here. It means this is going to be part of C4 that broke off, and there's widening of space between C4 and C5. So widening of space C4 will be something like this, and C5 will be something like this. Widening space between them, correct? And there's a bone fragment over here, triangular bone. So this goes into, and the head is something like here. So this goes into flexion. This is flexion, hyperflexion. If it went this way, then it will be hyperextension. So this is what they are saying. Small triangular fragment of bone anterior and inferior to the anterior margin of C4, with binding of spinal cord of C4 and C5 mechanism, hyperflexion. Similarly over here, hyperflexion, hyperflexion. These are both flexion teardrop fractures. This flexion teardrop fracture occurs in hyperflexion of the C-spine. Question number 40. CT scan shows subdural hematoma. MRI shows high signal on T1 and low signal on T2. How long is it that injury was sustained? 3 to 7 days. Because of intercellular methemoglobin. Okay, now look here. Intracellular methemoglobin, so high on T1 and low on T2. Now, if you remember the mnemonic, I bleed less than 1 day, I die 1 to 3 days. Okay, I bleed ISO, T1 is ISO and T2 is bright, so less than 1 day. I die, so T1 is ISO again and T2 is dark, so 1 to 3 days. Bleed die, T1 is bright and T2 dark, so 3 to 7 days. Bleed, T1 and T2 both are bright, so 7 to 14 days. Uh, 7 to 14 or 28 days, and die both T1 and T2 are dark more than 14 to 28 days. E is simple, remember, first is less than 1 day, then 1 to 3 days, then 3 to 7 days, then is 7 to 14 or 28 days, and then is 14 to 28 days. This is only 7 to 14 days. Then 14 to 28 days, and then is 14 to 28, done. Now let's go. Question 41. High speed RTA factor was seen running across the right temporal bone. A little bit easier. When 41 high-speed RTA factor was seen running across the right patellary temporal bone, extending from the squamous portion of lateral to the mesotympanium immediately, where the patient most at risk of ocular dislocation. So first, let's look at this image. First image shows the image axis on longitudinal temporal fracture. If longitudinal temporal fracture occurs in temporal bone, it will occur across this path. Longitudinal temporal fracture. Now, second image shows perpendicular axis of transverse fracture. This perpendicular image of transverse fracture. Transverse fracture will occur in this direction. Transverse fracture direction, and this is longitudinal fracture direction. Correct? Let's look at this longitudinal fracture. Predominantly longitudinal fracture of the right patellary temporal bone. Okay, this is normal. The abnormal, this is the longitudinal fracture of the right patellary temporal bone. It's over here. So, with complete disruption of the ocular chain, normal anatomy is well demonstrated on the left side. The normal and the disruption fracture of the temporal bone right side. Okay, a patient was running across the right patellary temporal bone. Okay, running across fracture was running across right patellary temporal bone, extending from the squamous portion lateral to the mesotympanium medially. So here, the mesotympanium medially and the squamous portion laterally. So mesotympanium medially and the squamous portion of the temporal bone laterally extending. So the diagnosis is longitudinal temporal fracture and there is risk of ocular dislocation.
Sorry, we see the description of this diagnosis kindly.
Is this read कर लूँ?
Sir,
अच्छा.
yes, sir.
Fracture was seen running across the right patellary temporal bone, extending from the squamous portion laterally to the mesotympanium medially, where the patient was at risk of ocular dislocation. But in the MCQs, whenever they say there is a fracture of temporal bone, then the patient will be at risk of ocular dislocation. ठीक है? Question number 3042. Grave disease. Technician 99 amper technetate. What is the scan likely to show? Diffuse airway uptake and uniform pattern. The normal thyroid scintigraphy. The grave disease. Diffuse uptake in the in a uniform pattern. Then autonomous nodule. Okay. Now here they were saying that grave disease technician 99 amper technetate. What is scan likely to show? Diffuse airway uptake and uniform pattern. Diffuse airway uptake in a uniform pattern. In Hashimoto disease, there will be decreased uptake. Question 43 are day history of increasing confusion following by three generalized seizures. Amplified with extensive high signal in the temporal lobes and frontal lobe. So extensive high signal in the uh, temporal lobes and the frontal lobes with multiple low signal foci on T2-GRE, multiple low signal foci on T2-GRE. Diagnosis: herpes encephalitis. These are T1, sorry, these both T1. But the important thing is that herpes encephalitis, there's unless there's abnormal meningeal thickening and enhancement, and that there's multiple extended signal, high signal in the temporal lobe and frontal lobe. So diagnosis: herpes encephalitis. These are herpes encephalitis, same meningeal enhancement and multiple high signal foci in the temporal lobes and frontal lobes. Question 44. This can show a well-defined uniform enhancing lesion with marked vasogenic edema in the right temporal lobe adjacent to the petrous ridge. On the MRI appeared hyperintense on T1 and hyperintense on T2 images. On WWI there was high signal and low signal on ADC map. Was study diagnosed cerebral abscess. One hint is because on GWI there was high signal, so there's more cellular content in abscess. Another thing is that a thin warm uniformly enhancing lesion with marked edema in the right temporal lobe, here left on right temporal lobe, and then so all these uh, signs gives us diagnosis of cerebral abscess. Question 145. Immunocompromised patient, male, CT scan has three discrete hyperdense lesions in the corpus callosum and center of submural. First of all, this is glioblastoma multiforme. This is lymphoma, CNS lymphoma. Now we are discussing lymphoma. The immunocompromised male CT scan shows three decreased hyperdense lesion in the corpus callosum and central submural. Discrete hyperdense lesion in corpus callosum and centrum submural, but partial enhancement with eastern necrotic area was seen. Now post contrast there will be eastern necrotic area, but we cannot see it here. You just can see three discrete hyperdense